Hello folks, Kofi here again and welcome to my YouTube channel, TutorMed, where everything medicine is simplified. I work as a medical officer at the Holy Family Hospital, Techiman, specifically with the Department of Internal Medicine and Therapeutics. Clinicians always encounter patients with various presenting complaints, and it's our duty to use the clinical methods to fish out the culprit behind the patient's problem. So in this video, we will look at one of such clinical struggles, the clinician versus the adult patient with chest pain. How does a clinician use the established clinical methods, a history, physical examination, and investigations to get to the root of the problem? In our previous videos, we simplified the art of an excellent medical history taking, the interpretation of the hepatitis B profile, and full blood count. Kindly find in the description below the link to these videos and get started if this is news to you. Particularly, you might need a video on medical history taking to appreciate this lecture. Kindly subscribe to the channel if you haven't done that yet, like and share our videos, and let us know your thoughts in the comment section. Alright, let's get started. As a reminder, please recall from the medical history taking lecture that differential diagnosis should be generated after the patient's demography, presenting complaints, and its duration. Now, if this young male fellow came to you with complaints of chest pain, what will be the most likely culprit, and how do you intend arriving at the diagnosis? Will the most likely diagnosis be similar to this elderly aged man, or you will consider a different diagnosis as a likely culprit? More importantly, how do you intend arriving at the diagnosis? This makes me want to stress the point that clinicians are not soothsayers or diviners to diagnose patients based on how we feel or by looking into a calabash of water. We make diagnoses based on an excellent history, a thorough physical exam, and then rational use and interpretation of diagnostic tests. And whenever possible, we should be able to defend or provide evidence to support a patient's diagnosis, and again, to provide evidence to refute other potential diagnoses. Alright guys, like we always do, let us get some basic understanding of the complaint. The first principles. Let's first look at the gross anatomical location of the chest. First, the thorax is the part of the body between the root of your neck and your abdomen. It has an anterior part, which is known as the chest, and a posterior part, known as the upper back. The chest consists of the chest wall and the visceral organs in its cavity. And the patient who complains of chest pain most likely has a pathology in any of these structures, either the chest wall or from the organs within its cavity. Sometimes, the cause of the chest pain might not be organic, but from a psychological process, like anxiety. The pathology, if organic, could be due to an inflammatory process, from an infection, ischemic event, autoimmune process, or sometimes it could be neoplastic or traumatic, or even another pathologic process. Now, having understood which structures make up the chest, let us review a very simplified concept of pain. What is pain? Pain is an unpleasant feeling or sensation usually caused by illness or injury. Whenever there is a pathological process going on in any part of the body, say inflammation in a chest structure, the sensory nerve endings within that structure are stimulated, and these send impulses to the neurons in the spinal cord, which also send those impulses to the brain to be interpreted as pain. So for example, if you have an inflammatory process in the pericardium known as pericarditis, the sensory nerve endings within the pericardium send impulses to the spinal cord, which are further transmitted to the brain, and the brain interprets this as pain coming from the chest or the pericardium. Alright folks, please do not forget to subscribe to our channel, like and share our videos. Please recall that we said the chest is made up of the chest wall and the organs within its cavity. The chest wall consists of two main organ systems: the integumentary system, which is basically the skin and the subcutaneous tissue, and in females, including the breasts. A pathology here like cellulitis can present with chest pain. Second, the musculoskeletal system, which is made up of the rib cage and muscles like pectoral muscles, intercostal muscles. And so muscle strain, rib cage fracture, can lead to chest pain. These are the structures we should be thinking about if we suspect that the culprit might be in the chest wall. Now let us review what the chest wall looks like. So this is the musculoskeletal system, which houses the internal organs of the chest. Kindly note that this is an overly simplified diagram without most of the anterior chest wall structures or muscles like the pectoralis major and the rest. The muscles shown here are the intercostal muscles. In front of this system is the integumentary system, which is made up of the skin and then the subcutaneous tissue. With this, we should be able to tell which structures grossly make up our patient's chest wall, and then how they are arranged. The skin first, and then the musculoskeletal system second. And we should note that chest pain could come from any of these structures. Very good. Well done for following the lecture till now. Next, let us look at other structures of the chest, the internal organs. To put the internal organs into perspective, let's begin with posterior structures. And so from the back, the first structure we want to mention is the thoracic spine, which is made up of 12 thoracic vertebrae. The next in line is the GI system, specifically the Oesophagus. Next is the heart with its pericardium and the great vessels, the aorta and the superior vena cava. Next, we have the trachea with the right and left main bronchi. And then lastly, the lungs, the right and the left lungs, each with their pleural membrane. These are the structures which grossly make up the chest cavity. However, there can be other structures like the lymph nodes, the thymus, etc. A patient who presents with chest pain could be having a pathological process in any of these structures. Let us label the structures again. We have the left lung, the right lung, each with their pleural membranes, the heart with its pericardium, and then the trachea, the oesophagus, the thoracic spine, and then the great vessels, the aorta, and the superior vena cava. But the structure labeled here is the arc or arch of the aorta. And so summing it all up with the clinician's eye, this is how the clinician should be imagining the patient's chest. From the back, we have the thoracic spine, then the oesophagus, then the heart with its pericardium and the great vessels, the trachea and the bronchi, the right and left lungs, the rib cage with the sternum and the muscles, then the subcutaneous tissue, and then the skin. And so the next question, after the clinician has created a mental picture of the patient's chest, is, where is the pain from? Is it cardiac or pericardial in origin? Is the culprit in the great vessels, principally the aorta? Is the pain from the respiratory system? Is it from the lungs, its vasculature, or from the trachea, or from the pleural membranes? Is it from the oesophagus? Is the pain from the musculoskeletal system? Or are there any subtle places in the chest the pain is from? So these are the possibilities the clinician should be considering in this clinical struggle. And so we will look at the various common conditions that affect various chest structures. Great, folks. So now let's look at the various conditions, beginning with the heart and its covering, the pericardium. The common conditions which affect the heart as far as chest pain is concerned can be grouped into ischemic and non-ischemic pathologies. For ischemic heart diseases, basically there is a reduced blood supply to the myocardium because the lumen of the coronary artery is reduced, either from vasospasm, a thrombus, an embolus, or because there is a reduced blood flow through it because of a reduced cardiac output, as occurs in aortic stenosis. So it could be because of stable angina pectoris, unstable angina pectoris, myocardial infarction. We will look at these three into details later, but the difference is that in stable angina pectoris, chest pain is precipitated by activity and relieved by rest. In unstable angina pectoris, even at rest, there is still chest pain. And in myocardial infarction, the ischemia has progressed to the death of heart muscles or necrosis. Then lastly, we have aortic stenosis, which causes reduced blood flow through the coronary artery, thereby resulting in ischemia. For the non-ischemic heart diseases, we have inflammation of the myocardium, known as myocarditis. We have conduction disturbances, known as arrhythmias, and then mitral valve prolapse. Then we turn to the pericardium. The pericardium can be inflamed in a condition known as acute pericarditis. Or sometimes the pericardium can be stretched by excessive fluid within the pericardial space called cardiac tamponade. And so how about the great vessels, particularly the aorta? Thoracic aortic aneurysm, which is simply a bulge of the aortic walls, can compress on chest structures to give chest pain, but most often patients are asymptomatic. The second pathology here is aortic dissection, which is a tear in the tunica intima of the aorta, resulting in separation of the walls of the aorta, and can also present with chest pain. So then, what can occur in the pulmonary tree or the respiratory system to give chest pain? 1. We have the infection of the lung parenchyma, otherwise known as pneumonia. It could be bacterial or mycobacterial, or even viral or fungal. The next, pulmonary embolism, which can be a massive pulmonary embolism or a small pulmonary embolism. Next, we have bronchitis and then pneumothorax, pleural effusion, pleuritis, the inflammation of the pleural membranes, possibly from connective tissue diseases like SLE, rheumatoid arthritis, and last but not the least, malignancy of the lungs or pleura. Let us now turn our attention to the differential diagnosis from the esophagus. It could be as a result of gastroesophageal reflux disease, oesophagitis, which is the inflammation of the esophagus, either from the acid reflux or from infections like candida, known as candidal oesophagitis. It could be due to esophageal spasms, Also, we have malarialized tear, which is a longitudinal mucosal laceration in the distal esophagus and sometimes the proximal stomach, usually associated with forceful vomiting or retching. And then it can also result from esophageal perforation, also known as Boyhar's syndrome. Now on this slide, let us consider a mnemonic which will help us to remember the esophageal causes of chest pain. Let's say an exercise was conducted for Ghanaians and over 1 million Ghanaians opted out. That is the mnemonic. Over 1 million Ghanaians opted out. Over for esophagitis, 1 for esophageal rupture, million for malarialized tear, Ghanaians for GERD or gastroesophageal reflux disease opted out for esophageal spasms. For the musculoskeletal causes of chest pain, we have costochondritis, also known as TSC syndrome. It could be as a result of trauma, which can result in soft tissue injury or bone fracture. Could also be due to an acute enteroviral illness, which is characterized by fever and sudden spasms of the chest and abdominal muscles. This is known as pleurodynia, formerly called Bornholm syndrome or epidemic myalgia. It could also be due to cervical disc disease. And lastly, it could be due to malignant chest wall involvement, metastasis to the chest wall from a primary site of cancer. Again, on this slide, let us consider a mnemonic which will help us remember the musculoskeletal causes of chest pain. Here, we are asking a question, and the question is, can trauma cause musculoskeletal pain? That is a mnemonic. Can trauma cause musculoskeletal pain? Can for costochondritis, trauma for traumatic chest injury, cause for cervical disc disease, musculoskeletal for malignant involvement of the chest wall, pain for pleurodynia or Bornholm's disease. Now let us consider other causes of chest pain. It could be due to herpes zoster infection, which is actually a reactivated varicella zoster infection. It could be due to acute chest syndrome, which is very important to consider if our patient has sickle cell disease. We have psychiatric conditions like anxiety, depression. It could be due to mediastinitis, inflammation of the structures within the mediastinum, or mediastinal malignancies or masses. It could also be due to thoracic outlet syndrome. Now let's look at evaluating chest pain at the emergency room. At the ER, there might not be enough time to consider all these differential diagnoses. Some have devised the 4-2-1 rule, which considers 4 cardiac causes of chest pain, 2 pulmonary causes, and then 1 GI. And these causes are potentially life-threatening causes of chest pain, and so they need to be ruled out at the ER. For the cardiac causes, we have acute coronary syndrome, which is made up of a triad of, or a spectrum of, unstable angina, non-ST elevation myocardial infarction, and then ST myocardial infarction. Then we have aortic dissection, pericarditis or myocarditis, cardiac tamponade. For the 2 pulmonary causes, we have pulmonary embolism, pneumothorax, and then for the gastrointestinal cause, we have esophageal rupture. Alright guys, and so if you are not at the ER and you want to completely evaluate a patient with chest pain, you need to evaluate all the chest structures And this is a mnemonic which will help us to remember all the structures we need to evaluate. Chest, room. So C for the cardiac and the vascular, so the heart and the great vessels. R for respiratory tree. O for esophageal causes, O for the other causes, and then M for the musculoskeletal causes. Alright guys, so what we have essentially done in today's lecture is to generate differential diagnosis for chest pain. In subsequent series of the adult patient with chest pain, we will look at all the differential diagnoses we have enlisted and their illness scripts, and also know the natural history of those diseases. If the illness script is new to you, kindly refer to our first video, but basically, it is a script made up of the risk factors and clinical features of a disease. By clinical features, we mean the symptoms and then signs. We will also take a look at diagnostic tests for these conditions. Alright folks, some take-home messages. 1. Create a mental picture of your patient's chest to appreciate what is really going on. 2. Use the acronym CHEST ROOM to consider all the chest structures which need evaluation. 3. When at the ER, use the 4-2-1 rule to rapidly evaluate life-threatening differential diagnosis. And lastly, get an illness script for the various differential diagnoses you have enlisted or generated. Thank you for watching the video. See you in the next video, still on the adult with chest pain.